That's it. And she works in Garrison and Balik as well. We have Lynn Gordon, who's from the opposite end of the country, and she works as an independent practicing physiotherapist. She's over 30 years in the game as well. She farms with her husband Mervyn, and it's a mixed dairy and poultry farm outside Garva. And she also sits in the Rural Affairs Committee at the Ulster Farmers Union. And we also are hoping to have Evelyn, who's a registered nurse practitioner. And she has a wealth of experience of district nursing, community nursing, and she has pioneered some innovative solutions to chronic disease management with groups in her practice down at Maple as well. So thank you so much for joining and being part of the panel. And in regards to everybody else, we're going to, after that, have some breakout rooms and a chance to network and discuss and focus on some of the solutions around some of the issues that we've found. So we'll maybe move on just to introduce the other side of the host. So this webinar is hosted by RCGP Rural Forum, as well as the Northern Ireland Agri-Rural Health Forum. So that is just a collaboration of businesses, charitable bodies, public bodies who have gathered together to kind of just try and inspire better health and well-being amongst our farm families. And that's in recognition to a lot of the pressures that we've seen over the number of years, and just try to gather expertise and bring folks like you who are also as equally passionate about farm families together. So without further ado, I will hand over to Dr. Miriam Dolan to give us a bit of background, and then we'll move on to the panel discussion. So, and I should have introduced myself. I'm GPST3 registrar, and Rebecca Orr. I live in Ballymoney, and we are lambing and calving at the minute too. So if you're running late or miss this, you'll be able to watch it at midnight whenever there's nothing else happening. Okay. So thank you very much. And Miriam, over to you.
Thanks so much, Rebecca. I'm trying to get Evelyn on the link, but there's a problem with getting into the meeting. So could you maybe send her the link again, and then we get her on.
Yeah, Miriam, Sean has just resent, so hopefully.
That's perfect. Yeah. Thanks. Yeah, so I'm just going to set the scene a wee bit. So when we talk about rural, we talk about farming families, I always think it's important that we just take a step back, and we all know we all are on the same line when we talk about, rural health and health services. And so if you can put up the next slide, please. So everybody has kind of a different kind of thing in their head when we talk about rural. It can be that you're thinking, well, it's the landscape, it's nice, and clean air and green fields, and sometimes people think that has more to do with population density, so how many people are actually living in small villages. Then what Rebecca said, we often associate it with farm families and farming. And when we talk about health services, of course, the first thing that comes to mind is access and remoteness, and how actually do we deliver health services to our rural communities. So if you can put it on that slide. So this is actually the definition of the Northern Ireland Statistical and Research Agency, and that's from the report from 2020. So really what they're saying, so in settlement with a population of less than 5,000 and areas of open countryside, that's really what we should see as, and that's their definition of rural. We also put another kind of, I say that they also say, well, it has to do with accessibility, and not only, of course, accessibility to health services, but also to schools, to opportunities, to jobs and things like that. So they would say, well, if you're living more than 10, if it's a population of less than 10,000 and you're having a long distance to drive, and they say 13 miles from a large population of 10,000, then you would say, well, that is quite rural. That is their definition, really. So next slide. This is a wee map of Northern Ireland. So this is the white areas. Then when you take those two criteria into consideration, then it is the white areas that would be seen as rural. Next slide. And then when we look at the UK, often when we talk about rural, we think about Scotland. But when you then take that definition in consideration, it's actually Northern Ireland, 36% of our population are living rurally. I think we always think about Scotland more because that has to do with remoteness. Often when I meet up with my rural colleagues in other parts, then the Scottish people always have a lot to say. But in a way, we should also have something to say, isn't it? Because it's 36% of our population are seen as rural folk people. Next. I also look at the difference between health and health services, and what actually do we mean with rural health. That's not always access to health services. So it's very much to do with prevalence and incidence, especially also then, of course, the occupational health when we're talking about the farming business. We can talk about infrastructure, transport, school services, but also about community development and social capital. So how actually are our villages connected with each other, and do they share a sense of belonging and they share a sense of identity. And then, of course, the fourth kind of factor is then the healthcare and health services. So the challenges. You go ahead. Yeah, go to the next one if you can. So then when we talk about challenges, and I always think it's good that first to look from the people's perspective, isn't it? So we know that there are specific challenges related to the characteristics of our rural populations and communities. And something that it often has to do with the nature of the rural industry and employment, and then of course also the difficulties with access to services, including connectivity socially and digitally. Then we have the issue with hidden rural poverty. A lot of urban people think that people are living in rural areas because they're living in big houses, that they have land, that they're rich. But we also know that a lot of people are quite poor, because the cost of living tends to be higher, and there's a lot of fuel poverty. But the report actually of the Bureau of Statistics did show that despite those unique challenges, living in rural areas are on average enjoy a better life and they live longer. So next slide. So then the challenges for health and social care providers in rural areas. Well, we all know them, isn't it? Retention and recruitment is a major issue, especially in primary care at the moment. There is the promise with knowledge, skills, and attitude, and because often as healthcare professionals and social care providers, we need different skills and attitudes and knowledge to be working in a rural area. Then we are addressing those specific health challenges of our communities, access and dilution of services. Often we see it with social care. The carers often have to travel longer distances, and it's extremely difficult to get social care in our rural communities. Access to emergency secondary care services, that is maybe all over really secondary care services, but again, sometimes what I find as a rural GP is that things like mental health or addiction issues, that people just will not travel to our nearest hospital. So often as a primary care team, we end up dealing with more complex issues. Then I already mentioned the digital and social connectiveness. Integration of services can be difficult, although it can be also quite local. Like we have quite good contact with our local. I see Jenny is on the line too. So we have a good contact with our healthy living center in Lissiski. So and you have the third sector and the primary care sector integrated with each other, which is great. And the career development sometimes can be an issue, and that is linked with retention and recruitment, because we are far away from the academic centers. Next slide, maybe. And this is just maybe you're all aware of this, but this is a summary sheet of the challenges really in the rural area. The next one. Again, this goes into, of course, we use the car more. We often have a higher cost to travel. That's actually the next one. Sorry. So this slide.
That's shown okay, Miriam?
Yeah, that's good. Yeah, this summarizes a wee bit, isn't it? So in disadvantaged rural areas, the drivers of poverty are also the drivers of ill health. And we, of course, are all very aware of that. And the health system, which is a determinant also of health, is often not sufficiently equipped in rural areas because of retention and recruitment and all the other kind of problems and challenges I mentioned. So it is a bit of a negative spiral, isn't it? But as Rebecca said, we're going to talk about opportunities and solutions. So next slide. And so we go now maybe ask our panel members. I see Evelyn has dialed in too, so that's great. So,
okay, hi.
Hi, how are you? Yeah,
I'm fine.
Really what I want to ask the panel members. I don't know who wants to start, but maybe Siobhan, could you maybe say something about what do you feel is one of the main challenges our communities, our farm families face with regards to looking after their health, and then of course also accessing and utilizing health and social care services. And then I was already talking to you about this, more about, examples, initiatives you have been involved with as a community pharmacist, but also as a practice-based pharmacist that are quite rural bespoke and could address some of the challenges we in our communities face. Okay, Siobhan?
Do you want me to do it now or in the breakout groups?
Yeah,
now?
Okay. Yeah, go ahead.
Okay, well, I suppose in terms of the barriers, Miriam, you've mainly gone through a lot of those. And that's exactly what I would see in community pharmacy. That
maybe we can stop sharing. Do you mind? Maybe stop sharing and then we can see Siobhan. Yeah.
There we go.
There you are.
Right. So you have probably hit on probably the main problems with for barriers to rural families, and I suppose the one that I would say most, and probably you see as well in your work, Miriam, is proximity to services. We're very rural in Garrison, I think we're the most westerly point in the entire British Isles. So for any of our patients to access secondary care, it's a 25-mile round journey to Enniskillen and back, and that's for probably routine appointments. I mean, if there was a major trauma, you're probably looking at going to Almagalvin or Belfast. But that would be one of the things. Health literacy as well, and that is something we would come up a lot against. You tend to find in rural families that people leave school at a younger age, so therefore they don't have the health literacy maybe that somebody that goes on to third level education might have. So when you're sort of saying to some of your patients, well, you can get that online, you do see the blank face, where they're sort of thinking, well, I might have to wait now for my son to come home at the weekend to access that information. So that is a problem we would find quite a lot, and we would spend time with patients printing off leaflets and things just so they can have that information. So I could go on for ages about the barriers. I see loads of barriers, but one thing that we have done in the past is the building community pharmacy projects. I don't know if any of you've heard of those. So it's basically an incentive set up by the Department of Health between particular community groups and pharmacists. So it's kind of getting the pharmacists integrated into the community. And we did one called The Farmer and the Pharmacist. And basically it was a rural farming group cross-border between Blake, Ballyshannon, Garrison, and these were a group of men that generally met in the off season, so in the winter season, and they discussed everything from how to make a will to how to get silo in this year, where to buy the feed for their animals. So we decided that health could be something we would bring in. So we did 6 classes with them, maybe in the pharmacist, and I enlisted other health professionals to come in. And I just made a list there. We did like farmer and minor ailments. We looked at things that maybe be very specific, and we included farming wives as well. So this wasn't specific to men, and their children could come to. So we did things like minor ailments that a farmer might suffer, for example, sunburn, allergies, looking at moles, advising, you know, cover up in the sun, that sort of thing. We did a night of cardiovascular testing. So we did blood pressures, diabetes, cholesterol testing, and we had made our local GP aware of this, so they knew if there was any referrals, so, you know, to be expecting it. We did a night of CPR training with particular emphasis on cuts, sprains. So we did the CPR, but we also did like minor injuries as well, cuts, sprains, and that sort of thing. And we did a night of men's health. And I think that was great at breaking down the barrier between men and their pharmacists, because for weeks after they were coming in, you know, every wee thing that was wrong, they felt that they could trust you, and they knew that you were an open point of access from 9 to 6, Monday to Saturday. So, so that was a really good initiative that we have done, and we've done loads of other things since. That was probably the biggest. So, yeah.
Yeah, thanks, Siobhan. Yeah, that is very interesting, because often the community pharmacies is very kind of low threshold, isn't it? That's where the people go first, and
yeah.
So, and if that's so much based on trust, so if they trust your advice, and
something like 130,000 people visit their community pharmacist every day, and we see things that you would not see across other health settings. We get an idea, for example, we actually did a project with trying to pick up hidden carers. So who picks up their medicines? So if you have a young 16-year-old boy picking up a medicine, maybe for a 55 to 60-year-old man, you do start to question what's the relationship there. And often they're a carer, and this child may have, you know, may have no support outside that household, and nobody may know about it. So there are so many things you see in a pharmacy that you might not see, for example, in the GP surgery, because you don't see them come in the door and go out the door. You just see them come into your room, but you don't see the lead up of how they got there. So it's often you just pick up those little things. So it's very, yeah.
I always think also about the case about the wee boy in Garrison that you picked up, that he lost a bit of weight and he had acute diabetes. You know, as a community pharmacist, you are so much in the community, isn't it?
Yeah.
And
we would just love to get those projects commissioned. So what the service you get from one community pharmacist isn't always replicated all across Northern Ireland, which is unfortunate. And it often comes down to money and time. So we would love to see that replicated, because I think in a rural community that would be really, really important. Obviously it's important in all settings, and urban as well, but if you live in Omagh, there's possibly 2 out of the 10 pharmacies that are there that are offering that service, whereas when you're in Garrison, you know, there's only the one pharmacy. If you're Balake or Belcoo or Derrygalley, there's only the one. So it is something we would love to see replicated all across Northern Ireland, but unfortunately it's not something that the board currently hold a lot of value on.
That's why they have the rural forum, isn't it? To have a voice,
Yeah.
I think, very much so. Thanks, Yvonne. Maybe Lynn, do you want to come in next and tell a wee bit what you see as a pharmacist, as a physiotherapist? What are actually the challenges of the rural community that you're working with, and have you been involved in any initiatives or that can maybe address those challenges?
One of the biggest challenges I often think is time, whether that is because someone's actually working 2 jobs, so they're going to struggle to get to health centre during sort of normal working hours, or whether they're able to take time off the farm to come into us as well. So it is where I live and where I work is very handy to the local hospital. It's about a 20-minute drive, but people still would like everything in their local health centre. So they don't want to travel irrespective of how far it is, I think. But we have been coming across a lot of the barriers are people who are working alone and who are, as a result of that, very lonely. So I work as part of a first contact practitioner team. So we have a social work and mental health officer in that team. So there's a lot of sort of interdisciplinary work in trying to direct people to different services that are already in the community. So there are, and then we have set up a men's group, which is a bit like the men's shed, which I'm sure a lot of you have heard of. So to try and direct some particularly older men who are on their own to that, and then to the Plough On project, we have access to that as well from rural support. So that probably has been one of the most beneficial things. We've just started also to address the farm and family, as in not the actual person who's doing the farming, but support for younger women with young kids who are isolated as well. So I'm trying to improve activity levels to prevent disease, and all of the promotion of good health and good diet as well. So but it's been very worthwhile making those links. And I think getting yourself established in the community is great, because people then trust you. So they will. My husband picks up patients for me all the time in the local hardware shop. So I trust, so it is good that you're there, people recognise that the service is there, and then the trust spreads. If you've treated mum, or you've treated granny, or you've treated their brother, or whatever, and that's the same for all the FCP team.
Very about connecting, isn't it? And you probably are aware also of the rollout of MDTs within primary care, and that a physiotherapist is part of the team, and social worker, and so it's almost bringing healthcare professionals out into the community to deal with people's problems in the community, and empower people that way. Yeah. And loneliness is a big one, isn't it? Sounds very good to link people in, and to have some kind of way of that people feel safe and talk about their issues. Yeah. And MSK is such a big issue, isn't it, farmers? Yeah.
Massive, yeah.
And often when you then dig down, why do you have the back pain? Yes, because they've been carrying, or they've been lifting a pal for lifting a sheep, or so. Yeah, it is about that preventative input. Yeah. Thanks very much, Lynn. Evelyn, do you want to maybe say something about the challenges that you see as a practice nurse in primary care, and also maybe say something about the initiatives you have been involved with to try to address those specific rural challenges?
Okay, thank you, Miriam. Thank you. Hi, my name is Evelyn, and I've worked in primary care for 20 years in a very large rural practice. And when I started there, it was probably about 7,500 to 8,000 patient population. And 5 years ago, we merged, 4 practices merged. So now we are double the size, we're about 16,000. Very rural parts of it. And I would have worked in chronic disease management for a number of years, and diabetes and cardiovascular disease was the areas that I were working in. And of course, you get to know people very well, you get to know their families, you make connections, and generally you are trying to address in a very short time, maybe 10 to 15 minutes consultation about their problems. And, you're trying to focus on a specific area, but you find that there's many other issues and problems that they would like to address in that short time. So I have, made, I suppose, a lot of networks and connections with people, and I'm a member of the Royal College of Nursing. And as a learning rep, I would come across, obviously, with my fellow colleagues in rural practices, they face the same difficulties. So in 2019, just before the pandemic, I had discussed with the GPs that I work with about running something like a group consultation. And then COVID came, and so we were, I suppose, stuck with all what COVID presented to us. And a lot of the reviews for chronic diseases didn't really go as planned. And then when we had, I suppose, vaccination programs in progress, people were starting to ask about, when am I going to be seen? And I haven't had my diabetes review, even though we were doing our best to make connections with people digitally and through social media, and like through video consultations, what I meant to say. And then I got this idea. I was reading about projects that were happening in England and Scotland, and those projects were really related to group consultation, via the video consultation, group video consultation. And I realized that they've been doing this on a face-to-face basis for a number of years, and it's well established in areas of England and Scotland, not just in primary care, but secondary care as well. So I presented the idea to the GPs, and they said, particularly Miriam, who I work with, who said, yes, go ahead. This is a good idea. So now we found that, basically people were a little bit worried about sitting in a group and discussing their chronic diseases. But we assured them that, you know, it was confidential. Any participant in the group had to sign up to confidentiality. And, you know, that if they wanted to opt out, that was fine. We were going to still see them as we normally did. But we've got a lot of interest, and it's really good the way it has worked out. We did the training. So I trained with a group called ELC, and they're employed by the NHS to run training courses in health coaching and group consultation. And so some of my colleagues trained as well, my nursing colleagues, and we trained some of the administrative staff and assistant managers. And so they act as facilitators for the group consultation. So you could have maybe up to 12 members in a group, 12 patients, and the facilitator will really lead the consultation until the clinician comes in to discuss with the patient their diabetes results, and, you know, their HbA1c, their cholesterol, their kidney function, blood pressure, all of that is done prior. So we have a discussion there in the group, and patients are able to get involved and learn from other patients. Sometimes there's always people who are a little bit quiet and shy and not wanting to maybe talk too much, but there's others that will open up subjects, and in that way they learn from each other. And it's been very positive, and I must say we are you know, finding a lot of help from the Oak Healthy Living Centre. They're going to help us with the patients who aren't able to manage to link in. Some people are happier now maybe to have the face-to-face now that we've opened up. And we're going to offer them either or, you know, it'll be 90 minutes if we have about 12 patients. And so that's once a year for your annual review. And then if we need to see them at other times, we can have maybe smaller groups. But what we know is that the evidence is that this works really well, and that patients have never, in all the studies that have been done, because this has been happening in America as well for many years, patients haven't ever complained about confidentiality issues. Once they've signed, once they see the way the group consultation is run, they trust you, as you had other multidisciplinary team members have said. They do trust, you know, that you are trying to run a consultation for the benefit of all patients, and that the goal is that patients will learn from each other. They will take their condition, that it's theirs, and they live with it, and we only see them for a short time. And it's really an important thing, really, to take ownership of your chronic condition. And people do better when they are more involved in understanding what they need to do to stay safe and to stay healthy. And what I remember from doing the one-to-one face-to-face was there was always a little diversion to talk about different things, you know, and that wasn't easy to sort of say, well, I can't really talk about that, because sometimes it could be depression. Sometimes it could be, you know, a marital breakup. It could be, you know, maybe an addiction. And that was the time they could talk to you about that. And we hoped still to keep that face-to-face, but the group consultation is a great way to do group work. And so that's our initiative in a rural practice. So we're hoping to get up working and see more patients as soon as we can to catch up, because COVID has obviously left us, you know, not been able to see as many as we would have liked to have in the last few years.
That's great. Thanks, Evelyn.
So, not at all.
Yeah, no, it's about kind of thinking, isn't it, outside the box, and trying to make it patient-centered and empower people.
Yes, exactly. That's it, yes.
Very good. And it can work so well, isn't it, in
yes,
the rural area?
It can work really well. And the trainer who we have been in touch with many times about different difficulties we were having getting started, she has said that she has seen it being used in many different areas. So I mean, pain management. You could use it for, asthma reviews for patients for even children, teaching them the technique of using inhaler technique. There's so many different areas, people who are suffering with mental health problems. Sometimes they can sit together if they're suffering, and, they like to know how people manage to get through day by day. It's not suitable for everybody, but it's suitable for the majority of people, I think. It's something we'd hope to roll out further, maybe in different areas.
Thanks so much. Yeah.
No problem.
I was writing down a few themes that came up through the panel discussion. So really more the loneliness and the specifics of our rural communities, the loneliness. We want to help people to connect through different initiatives. Talking about especially about preventative medicine, and trying to keep people healthy, and when they do have then maybe a chronic disease, to again work on that and empower them to do that. Yes, it's great to really share kind of bright ideas and things that are going on, isn't it? So I don't know, shall we now, I don't know, Rebecca?
Yes.
Shall we? Yeah.
That was a great discussion, and I think there's a theme of chatting, and certainly I'm sure others in the group who are familiar with farmers, once you get them chatting, it's hard to get them stopped. So that's one thing about the community, and certainly loneliness is maybe a barrier there as well, and that also creates some networks that otherwise might not have been made, and gets those kind of unofficial mentors going that maybe are a bit further on in chronic disease and can give ideas and feedback. And I love the idea of sort of Mervyn acting as a referral point from the local hardware store, because that's obviously where our farm supplies come from, is a big forum for the farming community, and a lot of stuff's discussed there, as well as the marts. And that's why it's great to work across the barriers and reach out to the whole community, including industry and businesses, because really that's where you get to the heart of some of the issues. And as you say, Evelyn, mental health is a big problem, and that can feed into your consultations as well. And we're all under pressure with time and resources at the minute. So thank you so much. And Miriam, thank you for your presentation. We're going to move into breakout rooms now. So if you get stuck at any stage, just simply rejoin the meeting, and Shauna will be in the main waiting room and she will redirect you again. So don't be afraid. We're only going to have one switch. We were planning to have two switches, but we'll just stick with one so that we allow you plenty of time to get to know each other and network. And we've got a bit of a task in that we'd like each group to come back with some feedback on your thoughts and ideas, maybe something existing or maybe something that you think would be a great way to engage with our farming families better. So we'll maybe do that now, Shauna, and certainly if you have any questions or queries, just pop them in the chat as well. We're really glad to take any thoughts any which way. So I'll hand over to Shauna now to kind of do that wee bit. You just have to accept your breakout room. Thank you, Shauna. Did you retrieve everybody?
Yes, I think that's everybody back in now.
Very good. I hope everybody had a good discussion. I don't know about you, but in our group, we kind of got, it was a very brisk end to because everybody was chatting that much. So I guess, will we just go through in a numerical order? Does everybody kind of know breakout room 1? Who would like to speak from breakout room 1 on? And I mean, if you only came up with one solution, or if you didn't come up with any and you just got to know each other and you want to make a comment, it's fine, absolutely fine. Is there a speaker?
Were we breakout group 1? I'm not sure. Is it our group?
No, so it was Miriam's group.
Miriam's group, perfect.
I don't know. Maybe somebody else wants to. I wrote down a few things that we came up with. And make it kind of rural bespoke, so and go out to the communities, make it cultural adapt. So I think Anne was saying, they have maybe a little bit of a banter and talk about farming, or try to break that barrier, get that trust. We also talked about continuity, especially in primary care, sometimes you're just not able to that there's one doctor in every village. That's sometimes just not possible anymore. So have continuity of care as a team, as an MDT team, and that people trust you to deliver their health services. So that is maybe a little bit of a change in culture. And I don't know what there are a few. What other things did we come up with?
That's that's good. Yeah. Is there anybody else from Breakout Room 1 that wants to make a wee comment, or will we move on? And then who is next, Shauna?
Evelyn's group was number 2.
Oh, okay. Yes, so we had an interesting chat about Laura was telling us about her work with voice notes messaging for the ethnic minorities. And I had been saying that at the practice that I work in, there's some parts of that rural practice that's very remote, and they're probably 20 miles away from the practice, maybe 20, 25 miles. And sometimes, you don't realize that you hand them, when they do come in, you might hand them like a printout of something. And, you don't know if they're able to read. This is the problem, you see. There's a lot of illiteracy as well.
Yeah.
And then we Laura suggested something about the voice notes that they use for the ethnic groups. And it's like a WhatsApp message that you, maybe you'd like to explain it a bit better, Laura?
Yeah, so it's something that we've done recently with Lifeline. So Lifeline's crisis, the 24/7 crisis helpline that we have. And notoriously, there would be low calls from the ethnic minority communities. All of the calls that come through to Lifeline are monitored. So it was, last Christmas, I think through some drug and alcohol work, they'd done key messaging on drink driving, and not driving if you've had a drink. And they're recorded in the top 20 languages, ethnic minority languages in Northern Ireland, and then they're put on as voice notes, and then gatekeepers in the ethnic minority communities can share them on the WhatsApp groups, because quite often they would have WhatsApp groups, like a Bulgarian community locally will have a little WhatsApp group and they'll share information on it. So the voice notes were sent out via that, and they were really well received. So we've done it for Lifeline as well, to create awareness about the Lifeline support. And they would have translators available, so that if somebody calls from a different ethnic minority group, that they can get access, they can get help if they're in crisis. So it just got me thinking about accessibility of messaging, and if there are literacy issues, is there something that could be done with the farming community in terms of voice notes? And obviously you're going to have to rely on those that are maybe a wee bit more tech savvy if they have WhatsApp on their phones, but it might be suitable for a certain group of farming community. And I think the other thing that we mentioned, Evelyn, was the farm families. And yes. I actually see Doreen's here, isn't she? Yeah, she's waving there. So Doreen's here. So I was just trying to connect Evelyn and Doreen there with the Farm Families Initiative to see if that would be servicing Evelyn's area as well. So we had a good wee bit of discussion about lots of different things.
Christina's on the call, Christina Faulkner. She's now managing that. She's out on a daily basis with that service.
Oh, brilliant. Well, there you go, Evelyn. There's Christina. You're linked up now.
That's brilliant.
Great. We'll move on. I really like that idea about the WhatsApps, and I'm sure all of you who have connections, there's a lot of farming WhatsApp groups, and the Facebook farming forums, and I buy sheep and sell and whatever, is more active than a lot of forums. So that would, trying to meet through a lead-in topic, as you say, Laura, is really good.
Yeah, and it could just be your key messages, you know, if it's relation to like cardiovascular health or your diabetes health, it could just be some simple key messages that you could push out through that mechanism, and might hit home.
Yeah. Shauna, will we, the next week group?
Yeah, so group number 3 was Siobhan's.
So we had great diversity across our groups. We had lots of different people from different areas of health. And we had Kelly, who is an agricultural consultant, and Kelly is doing her master's in farming. Basically, it's called Farmers Working Acres, Not Hours. So basically checking, what the farmers are up against, loneliness, long days, financial crises, that sort of thing. But Kelly had told us about a group that was in her local area called the Plough On group, which is quite interesting. It was a men's group where there were semi-retired men, generally over the age of 65, but they would accept younger men. They met once a month and they went out and about and, talking to each other, going places, and it's currently planned for about 18 months. And she said the feedback was absolutely brilliant, particularly because that age group was particularly impacted by COVID. So so groups like that would be great sort of going forward. We spoke a fair bit actually about, again, health literacy and connectivity. So Siobhan is a health planner, and she had been involved in the Pathfinder project. We did talk about, what possibly would help the farming community is having all our projects and different services sort of that may be navigated by a central navigator, and have, you can be sort of directed to hubs and like a directory for the community to use, rather than, and even tonight when I'm sitting here and I'm finding out about all the different projects that's going on, there's nowhere where all that's collated together. So if we find it difficult as health literate people, how would, a farmer that maybe doesn't have the health literacy, access that information? Actually, like Laura just said about the voice notes as well, I thought that was very interesting. But Jenny Irvine is in the Healthy Living Centre in Irvinstown, and Jenny mentioned a mental health resilience project that they're currently running. I'm just going to share more information with that with us all later, but it's free and open to anybody in the farming community, and it's either in person or online. So it's basically mental health resilience. So and another thing that came up quite a few times in our conversation, which I might start mentioning to my patients, is to go on the Rural Support Facebook page. Apparently there's quite a lot of information on there, so that's just one very basic thing that we can do for our farming communities. If they have access to internet, just advise them to go on there.
Perfect, thank you, Siobhan. And that was is it ourselves next, Shauna?
Yes, you're great, Rebecca.
Does anybody else want to speak, or will I think we came up with a good, we had a good chat. We had a broad range as well of folk in our, and certainly trust was a big thing that came up, and that was sort of emphasizing that if farmers can put a face to a name and they're familiar with you, and also even if you're not from a farming background, which Ashley says that she's not, but I think she knows a bit more than she says she does, that if you can even make a comment about the weather or something, a lead-in topic, it gets them chatting, and just having that rapport is an easy way to get them to come back if something else was wrong. And also through the groups, that's a proactive step. You're coming to them first and they have a face to a name. So that was one of the solutions that we kind of thought of, kind of trying to integrate that in a bit more. And also using the resources that we have was similar to Siobhan and other groups. We've quite a lot going on, and if we could connect together, it might be better, because I've learned so much already tonight of other initiatives that are going on that I didn't know about. And there was also another comment just saying about sort of bespoke groups for farmers, so even if you had a night that was something maybe about veterinary health, animal health, and then the equal, pneumonia in cattle and pneumonia in yourself, could you try to get them led in through those sort of themes? Because as we all know, kind of farming families probably care for their livestock more than their own personal health, which was a theme that certainly Liam from ABP in industry has noticed, that farmers are burning themselves out for the expense of maintaining the health and well-being of their livestock. So that's sort of the things we discussed, and I think we've got another group. We were breakout room 5, so I think there's one more.
Yeah, so Abine's group is the last one.
Best to last. No, I'm going to end up maybe repeating some of the comments that came through, but so it was myself from Rural Support, and we also had representatives from Farm Support and Community Health, and also a Rural GP and Healthy Living Centre nurse as well. So I suppose our solutions or discussions focused on 4 key areas. First one being access, so access to services for the farming community and how that's more unique and needs more consideration. So bringing the services out to people, and the brilliance of the Farm Family Health Check service was emphasised in our grouping, and how if that's partnered up with a local organisation who already have access to farmers and can encourage them to go along. Mark, our Rural GP, brought forward a great proposal in relation to video consultations. So for people who are living, for example, in Fermanagh and having to travel all the way to Belfast for a haematology consultation that might only take 5 minutes, but you've travelled maybe 4 hours, 5 hours in your day. So having, a local clinic that has the IT equipment that you just go along there and you're supported to get your consultation on site. The next point then was focused on information, and letting the farming community know what's abnormal. Mark referred to, someone coming in with a lesion on their forehead that, no one should really be living with, so knowing what is abnormal, that thing about looking after your animals better than you look after yourself. The next one then was infrastructure. So when the integrated care partnerships are being established, to have area-based planning that prioritise rural areas. So that leads into the commissioning of services. And if that doesn't happen, if that prioritised for rural areas doesn't happen, then they will miss out then in service provision. And then the last one was encouragement. So linked to the services that are out there, what local organisations and maybe ambassadors or champions can we have in rural communities that encourage people to go along to the services that are out there? And then again, sort of tied into them all is that communication piece, so that GPs, other health professionals know what services are available. So some form of a directory or information sharing on a regular basis. Mark made the valid point, if it's a funded service and the funding ends, the GP might will be thinking that's an active service. So trying to see how we can manage that. So really important information to take back, to this group and to the forum then going forward.
That was great. And Mark, you're there. I mean, that is just from a wealth of experience, obviously, some of the solutions that you're thinking of there. And obviously that was a late presentation with a skin lesion. And we all know that we've probably all seen that problem. There's a threshold that's higher in farming families because they don't want, they kind of do a lot more self-care. And certainly I should have mentioned another solution was that if we could plan that rural pharmacists or rural centres of healthcare provision actually have more skills than urban areas, if that was built into the forward planning and the funding and pathways for any healthcare providers to upskill that are established in the rural area and are settled in the rural area, that'll pay dividends for farm families and rural patients, because those professionals are going to stay in the local area, and if they can provide like a skin clinic or something at that sort of federation level rather and maybe the pharmacist level, that's going to maybe change that disparity. So that was something else that did come up. And the video consults is a really good idea as well for rural areas with the broadband. I know Ulster Farmers Union have done a lot of work in trying to ensure that there is parity with rural broadband provision, and that there's been some gains on that over the last couple of years, which hopefully will mean that there's less exclusion of farm families from sort of the digitalization that we're seeing across all our services. Because as you say, Siobhan, at the start, some people, so you say give them a QR code or something that's meant to be a quality improvement project, and it's not necessarily the most beneficial for our farming families.
Sorry, Rebecca.
Yeah.
Group 4 didn't get to speak, so Lynn's
Did
group.
they not?
Apologies.
Okay.
I'd be quite happy to be passed over, but
No.
there was just a couple of points that were
Good
really
job.
good that were raised. It was just the old thing, if you had unlimited money and unlimited staff, you could certainly provide a much better service. Accessing was one of the things we were talking about. And we did wonder if there was any role for pop-up clinics, like this has already been said, for example, at marts and things, you know, where people would have access to assessment by a GP or a nurse in a particular sort of discipline, or access to MSK service as well. In terms of access as well, Ian was telling us about the basic responders service. At the minute, that's a very limited service of, you know, maybe 11 or 12 doctors who will respond if they're available on a voluntary basis to emergency situations, especially seems to be quite a lot of farming accidents. And on the back of that, we were sort of thinking, you know, could we do a better job of educating younger farmers and younger farming family members, as well as the older ones, because, you know, the whole thing of a farmer never retires, and you find these 89-year-old men cuddling around the yard leaning on a piece of blue tubing, you know, are at high risk of something going wrong, as well as, you know, currently we target young drivers. And Ian was involved in this as well. PSNI and the ambulance service all came together to do education. Should we be adding in something into that about, you know, farm accidents and how you can promote safety and that type of thing as well? And we just mentioned about poverty then as well, you know, how there are areas of the country dwellers or rural dwellers, not necessarily all farms dwellers, but who don't have access to money for good quality food, and don't have the skills to cook food if they did have it, you know, as well. So issues with.
Yeah, because I guess the price of oil, you know, a lot of central heating out in rural areas as well, which is again affecting those rural families. I mean, Ian, I'm so glad that you were able to join. I didn't realize that we had you along tonight. But everybody, Ian is an emergency medicine consultant, and he is involved with Basics. And in fact, whenever I was disseminating some of the information from when we met, Basics is pre-hospital care in conjunction with NIAS, which is voluntary provided. So they all carry bleepers, and whenever something happens, they can attend and provide quite high level pre-hospital care, and quite often some of the barriers to farm families was even just getting to the farmer. So numbers at ends of lanes and locations, and I think, don't know if anybody knows, but what 3 words and those sorts of things are trying to break down the barriers to kind of getting out to remote locations as well. So Ian, thank you so much for joining, and I'm hoping that you enjoyed it. And certainly you know, do you want to make a comment maybe on that, Ian, just because it's part of care for farming families, and 10% of our ambulance callouts are to agricultural areas. So it'd be remiss of us not to mention that in the webinar. I know we're maybe slightly over time, but if you want to make a couple of comments, please do.
Yeah, I mean, I'm glad to come to this evening. As I've said to you before, the thing that always worries me is hearing that there's a farmer in resus a day job, because they have it's not like they've got a bit of them damaged. It's like, I had my arm here yesterday, I don't know where it's gone now. It's usually pretty serious stuff, and they're a bit like doctors. They're just very bad at asking for help and seeking help in a timely fashion.
Yeah, and that late presentation, as you say, is not good. I know. I remember in Craigavon ED seeing a dairy farmer who wanted to go home to milk the cows, but however was in quite a dangerous heart rhythm and he ended up having quite one of the worst cases of cardiac TB ever seen in the UK. So these things are happening in Northern Ireland, and it's really interesting, and we're really glad that so many people joined us tonight to kind of discuss some of the issues, albeit in a very broad manner, but more so to get to know each other and network. So is there anybody else wants to make a comment?
Rebecca, just one point on the air ambulance, because the air ambulance is very close to ABP, as you know. On the story of the farmer who was being contacted by the air ambulance to say they were on their way, said, "Could you wait to get the cows milked?"
Yes.
And that is the sort of feature. Just when we have so many people on there from Fermanagh, has the air ambulance really made a difference since its introduction in emergency and traumatic situations? Is there anybody in Fermanagh that could?
Yes. Yes.
Yeah.
Yeah.
Very grateful.
Yeah, and tell me, is the response time just the same as it is all over Northern Ireland? It's 19 minutes from the base. Sorry, it's 11 minutes from its base in Lisburn to it arrives in Portaferry, and I just was wondering how long it takes to get to the far reaches of Garrison.
Maybe Ian might be able to tell us that, I think.
Yeah, I'm not one of the HEMS doctors, but my good friend and colleague Davy Green, who also does basics, is one of the HEMS doctors. Basically, the flight times to anywhere in Northern Ireland, the farthest reaches it's between 20 and 25 minutes. Now you'll need to add on a couple of minutes there for the spooling up time and the tasking time at the beginning. But I do know that they have they keep a lot of details of each and every call, and there's a significant proportion of it is in the west of the province. It's not just Belfast centric; it is everywhere.
Yeah, and I know the farming community is hugely grateful for that service, and it certainly that was a massive solution to some of the problems with getting emergency care out, but certainly can't fly at night at the minute, and doesn't fly to every health emergency as such, which again is where Ian's good work comes in with the basics team. They're obviously on land, but we probably need more folks, and hopefully we're going to try and work together on something whereby we can upskill those who are in the community to have a bit more sort of CPR skills, as you mentioned there, which would be well into sponsoring. Barry Boyle, you wanted to maybe speak there?
I was just going to say, when you're talking about emergency and ambulance access, is the Fermanagh addresses still giving bother? Because there was a big change of address systems about 3-4 years ago, and I think a lot of our people are still using their own town land and not using their old name, which is on the ambulance sat nav, is what I was told, that they're using the new database. So I think maybe there needs to be a bit more awareness of that.
Yes, I think that's where, yeah, the GP, there's maybe a bit more work that we could do within the industry to kind of, as you say, get that mapping done easier. But we will take all of that back, and thank you so much to everybody who joined, and thank you so much to our panelists, Miriam, Lynn, Evelyn and Siobhan, for your insight and your willingness to share your experience. We are going to send out a pack, just a PDF afterwards, just to kind of summarize some of the services that are available. But certainly, as we've said tonight, there's maybe work there for a more detailed sort of directory of what's available. And certainly we hope to kind of keep this going. So most of you have given your consent to sharing information. So we'll invite you to another webinar, and we can get together again, and hopefully maybe face to face. There'll also be certificates of attendance issued as well for anybody that's used this for CPD. And again, thank you so much for your interest, and thank you to RCGP Rural Forum for partnering with us on hosting the webinar. So I wish you all a good evening, and I hope that Friday is kind to everybody, and if you're off, enjoy it. So yeah, thank you very much.
Bye.
True.
Thanks very much, Rebecca.
Bye.
All right. Bye.
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 Bye, Rebecca. Bye.
Bye.
Bye. Nice to see you all.